Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. At this time of year, we turn our attention to two common movement disorders by recognizing Essential Tremor Awareness Month in March and Parkinson's Disease Awareness Month in April. Both conditions are primarily diagnosed in older individuals. Parkinson's disease affects about 1 million Americans, while essential tremor, which is commonly confused with Parkinson's disease, affects nearly 6.5 million people in the U.S. So today, we're going to clear up the confusion about these conditions with Dr. Ann Murray, Movement Disorders Division Chief at the WVU Rockefeller Neuroscience Institute. Welcome, Dr. Murray, to Live Healthy West Virginia.
Thank you so much, Mary, for having me here. I'm super excited about this topic.
Yeah, we all are. We all are. Because there is a lot of confusion. So since essential tremor is one of the most common movement disorders, let's start with essential tremor. What is essential tremor?
Yeah, so you're right. So it affects 6.5 million people in the U.S. So it's very common, but often misunderstood of what it is. So when we think about essential tremor as a clinical symptom, so what would a patient experience? A patient experiences tremor when they're doing things with their hands often. So this is the type of tremor that comes out when I hold my coffee cup, when I go to write my name, kind of sign my name, when I go to text or type. This is what we call an action-based tremor, meaning the tremor is present when the muscles that have tremor in them are actively engaged in doing something. So this is holding a plate at the buffet, kind of drinking, eating, shaving, brushing teeth, all of those daily activities.
So if you were just sitting with your hands in your lap, they wouldn't be shaking?
Not usually. It's not to say essential tremor can never cause that kind of tremor, but it's really defined by the action-based component, the daily living kind of my hands are engaged in things, and that's when the tremor comes out. It can affect the head as well as the voice. Those are the three most common areas. But again, all of those things are affected when those things are in use, not necessarily at rest. Exactly.
Okay. Now, essential tremor is often confused with Parkinson's disease. So how are these two conditions different?
Is a really important point. So first, fundamentally, on the neurologist side or the neuroscientist side, these are fundamentally two entirely different diseases. Both diseases affect the brain, and both diseases can cause tremor, but the symptoms outside of that, and even the tremor itself, are entirely different between these two diseases. So what is the difference? So we just got done saying that essential tremor is really defined by a tremor when people are using their hands. Often the tremor in Parkinson's is more actually at rest. So oftentimes patients will say, you know, I don't notice the tremor when I go to eat and drink, but I do notice it when I'm sitting on the couch at night, my hands are rested on the armchair. That's when I notice it. The biggest difference, though, beyond tremor with Parkinson's is that Parkinson's actually causes many other symptoms in addition to just tremor itself. So Parkinson's can cause stiffness of the muscles, slowness and coordination problems that can affect walking and speaking and typing and texting in a very different way. So they might not be tremoring while they're trying to text, but it's like their thumbs just don't want to work well. They don't want to listen to them like they did before. So we call that coordination problem. And then Parkinson's can also cause a balance problem physically. So Parkinson's, in addition to tremor, can cause these other clinical symptoms that really, too, can impact quality of life. Okay.
Well, we started with essential tremor, so let's talk a little more about essential tremor, and then we'll get back to Parkinson's. What are considered the symptoms, then, of essential tremor?
So essential tremor, really kind of when we think of how did it get its name. So I first start joking, usually with patients when we talk about it, of there's nothing essential about it, right? Like they'd be very happy not having essential tremor. It's really called essential tremor mainly because it's tremor in isolation. It doesn't cause a lot of other diseases or a lot of other symptoms. Like it doesn't cause kind of a walking problem or a kind of a stiffness of the muscles problem. It really causes tremor in isolation itself. So the predominant symptom is tremor. And tremor is really defined by this kind of oscillation, or what we call movement across the joint space. And that's really the defining feature, or the defining symptom of essential tremor as a disease.
Okay, so who is most at risk then to getting essential tremor?
As you had alluded to in the intro, as we get older, the risk of getting something like essential tremor rises. So when we think of kind of the lifetime risk is even estimated up to 2%, but by the time somebody's in their 80s, up to roughly 7-8% of the population can have some degree of tremor. So in addition to age as kind of one of the risk factors, family history is usually the biggest predictor. So very, very commonly when we ask kind of patients' histories, they'll say, oh yeah, you know, dad had it, granddad had it, and all of his brothers. And that is a big part of actually breaking down kind of the stigma related to tremor, or kind of the barriers in treatment, is really saying, let's kind of look at this to where we can treat it and kind of normalize the conversation around tremor, because very often it runs in families, and oftentimes maybe they got treated, maybe they didn't, but we want to kind of change that conversation about tremor as well.
Do we know of any other causes for essential tremor besides hereditary?
Yeah, kind of, and just not really, actually. I mean, there are definitely medications that can cause tremor, not essential tremor as a diagnosis, but medications can cause tremor. Even caffeine to a certain degree can cause tremor. Other medical conditions like thyroid disease can actually cause tremor. Poor sugar control, like in a setting of diabetes, so really high highs or really low lows, can cause tremor. Those aren't essential tremor as a disease, but tremor as a symptom. And that is why it's really important with anybody that has tremor that they're really engaging with their healthcare professionals so they can work through what could be causing this tremor. Is it actually essential tremor as a brain disease, or is it some other reason they could be having tremor?
So how do you diagnose essential tremor?
It's a clinical diagnosis. What that means is it has kind of certain criteria. So the first criteria of it is that it's a primarily action-based tremor. So we have the tremor when our hand is moving, or whatever kind of part of our body that has tremor in it, it's activated with activity. In addition to that, we often can kind of, interestingly, in the criteria, often can see that alcohol can actually reduce the tremor. So it's not something that we're advocating as a therapy, but if you notice that, hey, if I have a glass of wine with dinner, it kind of really smooths out my hand, that really is indicative of this underlying kind of signaling problem in the brain that's causing tremor, and that alcohol can kind of calm that signaling down, which is why the tremor resolves. We have lots better treatment than alcohol. Again, that's not an advertisement to use alcohol as a therapy. Again, that's part of the diagnostic criteria. And really it should be, the diagnosis should be in the absence of other things, just like we talked about, that it's not a medication that we think is causing it. It's not some other medical condition that's causing the tremor. So we want to rule out those other medical conditions. So that's all in the criteria of diagnosing essential tremor.
Now, so generally, how is it treated? Because then I want to know about the really cool ways it's treated at the Rockefeller Neuroscience Institute.
Absolutely. So in general, the first thing is to kind of really understand, how is the tremor impacting a patient's life? And what I mean by that is, if somebody has a really kind of mild tremor and they say, yeah, it just annoys me, kind of, I just have a little shake of you know, my cup when I go to drink, oftentimes we can intervene there by just saying, hey, if you use weighted cups or kind of weighted silverware, you don't need a medication, you don't need anything else. We just need to educate you on what will dampen down that tremor so you can function better without taking anything or having any advanced therapy. Of course, for lots of patients, that's not enough, right? And so fortunately, we have lots of medication therapies. All of the medication therapies really target that signaling problem. As we spoke, fundamentally, kind of tremor is coming from an abnormal signal in the deep part of the brain that's causing tremor, and all of the medication treatments are trying to calm down that signal. Now, of course, we wish we had a cure for it, meaning I wish I had a medicine I could give somebody and make those signals normalize. But in the absence of that, a cure, we still have wonderful therapies. The medications are usually very well tolerated, easy to take, non-harmful to your heart, your lungs, your liver, your kidneys, easy to try, again, for this quality of life improvement. Calming down that signal. As we calm down the signal, it calms down the tremor and restores function.
Wow. Yes. So one of the really cool treatments, and see, I remember this from 5 years ago
Yeah.
when you know, we were first doing this at R&I. In fact, I think my voice is still on the video in the back, you know, when you were doing the test before the focused ultrasound. I know we should talk about what focused ultrasound treatment is first, and then I'll tell you this story.
Okay. So you're right, Mary. So we often talk to our patients about the fact that, of course, we're going to try to treat your tremor the easiest way possible, least invasive way possible, but never losing sight of the fact that the most important thing in tremor reduction is to treat your tremor so that people can live their life, right? And we're going to use whatever therapy we need to really impact that kind of quality of life piece of it. And so thank goodness we have the latest in all the technology in tremor treatment right here at the Rockefeller Neuroscience Institute. So that includes things like deep brain stimulation surgery, as well as focused ultrasound thalamotomy. And both of those therapies are targeted therapy to dramatically reduce that signal in the brain. And then when we reduce that, it treats the tremor itself and people live their lives.
Like instantly. I mean, that was the thing that just blew my mind, you know, like it just after a few, it was like 45 minutes and you were doing the, you know, you did the standard test at the beginning and he, you know, couldn't hold his arm. And then when he went like, and I went, I mean, it just...
I think your experience is exactly why I went into movement neurology. I often joke kind of with our learners, there's no more fun you could have in all of medicine than this instantaneous quality of life improvement. It's fun it never gets old, meaning that I enjoy it each and every time. It's such a privilege to be part of this journey with patients. But you're right, the technology is unbelievable, right? So whether we're talking about deep brain stimulation surgery, which is surgery, so oftentimes I think it's overwhelming to think about, but it's really important to understand that although this is brain surgery, it's really precision medicine at its finest. That yes, it's invasive, yes, it's brain surgery, but when I say precision medicine, unlike a medication, it actually, where a medication, when we take it, goes everywhere, right? Goes everywhere in the brain. That's often kind of the side effect side of it as well, right? So the benefits are there, but you can often have side effects. One of the beauties about brain therapy, targeted brain therapy, is the signal, the treatment is going right where we want it to go, right where the problem is in the brain. So the way deep brain stimulation surgery works is we make an incision, small incision in the scalp, put the little wire down, we connect that wire to a pacemaker battery that we put in the chest, and when we turn that battery on, that electrical current quiets that signal, right? If we have the tremor signal, it quiets it. As it quiets it, it quiets the tremor. Focused ultrasound, the experience that you got to see is different. It's a different technology. The way this technology works is it's a fancy ultrasound helmet that has over 1,000 ultrasound transducers in it. And we focus that ultrasound right in that same spot, right where the tremor cells live. When we focus it there, it burns them. And of course, the most fascinating thing about focused ultrasound is we can do that without ever making an incision, right?
No incisions.
Patients are just in the MRI machine. It's incisionless surgery. It's precision, but it's incisionless. And it's wonderful because both of those therapies are absolute wonderful experiences for not only the clinician, but the patient, because it, again, just like you alluded to, has an instantaneous quality of life improvement.
Both of them.
Yes.
It's just like that. I mean, it just still blows my mind. It really does. If you have essential tremor, is it considered life-threatening?
It is not. So oftentimes, actually, that is a good historical context. It used to be called benign essential tremor. And thank goodness we've dropped the benign from it, because although it's not life-threatening, and we're thankful for that, if somebody has tremor, it impacts their life every moment of every day. And if we can kind of imagine every time you go to brush your teeth, comb your hair, put on makeup, shave, put on your clothes, button your buttons, tie your shoes, having tremor that impacts every moment of every day, that's not benign. Yes, we're thankful it's not life-threatening, but it's definitely not benign. And the end of the day, what we want to recognize is it's completely treatable. And so people don't have to accept it as any necessary part of their life. We're too good at treating it to ever accept it.
That's great. It's really good to have that. Well, since essential tremor is confused with Parkinson's, let's talk a little bit about Parkinson's disease. What is Parkinson's disease?
So Parkinson's disease is an entirely different disease. It too is a disease of the brain. It too is a disease where there's signaling problems. Fundamentally though, Parkinson's disease is really from the brain not making enough dopamine. And when the brain doesn't make enough dopamine, I often describe it to patients as analogous to not having enough gas in the engine. So if I have no gas in the engine of my car, it doesn't matter how hard I slam down on the gas pedal or how hard I want to get up and go, I have no fuel in the tank. I can't just go, right? Okay. And so often patients, when we describe it that way, will say, yes, you're right. It's like, I know what I want to do. I'm telling my body to do it, and it doesn't want to listen, right? So there's a disconnect there. And that's fundamentally because dopamine is really this fuel to our movements. We need dopamine to move well and accurate and kind of with precision and speed. And so that's exactly what happens in Parkinson's. That lack of dopamine causes the tremor. So we're moving when we don't want to, we have the tremor, but then we also can't move when we want to, which is that slowness of movement. We call that bradykinesia. That's that aspect of Parkinson's that causes notoriously the symptoms we think of, which is the small short steps. We call that shuffling gait, the kind of dexterity problems, the small handwriting, soft speech, kind of different facial expression, all the other kind of symptoms we think of with Parkinson's. So the fundamental problem in Parkinson's is dopamine. When we think about solutions, it's going to be a lot about that circuitry and dopamine, but that's why the disease itself is very different. So it really is coming from a different problem in the brain, leading to different symptoms.
Is there a great range in of Parkinson? I mean, I think of Michael J. Fox, who was diagnosed, 25, 30 years ago?
Yeah.
And some people, that have just recently been diagnosed, and you hardly know that they have Parkinson's.
It's a really good point. So some of the big misnomers about Parkinson's is, one, Parkinson's also is not life-threatening. So Parkinson's is not life-threatening. It is not going to actually decrease your life expectancy, but it is causing symptom, right? So it does cause disability or kind of impact and quality of life. Right. But you're right, no two Parkinson's patients are the same, and no two Parkinson's patients will need to be managed the same. But one of the really important pieces to that point is really understanding that our ability to manage Parkinson's is actually tremendous. We have so many tools in our toolbox to manage Parkinson's patients, no matter their flavor of Parkinson's. We can manage it, and what we should be doing again is customizing their management to their disease, restoring their quality of life.
Okay, so how do you treat Parkinson's disease? What are the options?
Yeah, so fundamentally, we really want to come back to that dopamine problem. So the foundation of therapy is often dopamine therapy. There's several different kind of versions of that medication-wise. The most common of which is a medicine called Sinemet or carbidopa-levodopa, and this is really wonderful therapy. So
is this a pill?
Is a pill. So why I say it's wonderful therapy is often some of the some of people kind of in the Parkinson's world will often talk about, well, why hasn't there been a better medication, right? Why hasn't there been, Sinemet came out kind of 30, 40 years ago now, actually. And it's not because there haven't been efforts, it's really to say that's how good Sinemet is. So when Sinemet came out on the market, this was truly a miracle drug, right? Because before Sinemet came on the market, unfortunately, we had no ability to replace somebody's dopamine. And so they were just left with that lack of fuel in their engine, inability to move, inability to do things, right? Now we can treat it. And a lot about Sinemet therapy and the medication therapy itself, that foundation of therapy, is figuring out how much do we need for each individual patient. And what I mean by that is no two people are on the exact same medicine. It is the same medicine, but how we use it, how we take it, how frequently, what dose, has to be customized to that patient. It has to be customized to how fast their body metabolizes it, what degree of exercise are they doing, what are they doing, kind of what are their symptoms, and it has to have that nuance that it's not just a one-size-fits-all. We have to fit the medicine to their life.
Can you use focused ultrasound to treat Parkinson's patients?
Great question. So you can treat the tremor in Parkinson's with focused ultrasound, but unfortunately, focused ultrasound does not improve the coordination, balance, or stiffness of their muscles. So yes, it treats tremor very, very well, just like it does an essential tremor, but this is a really important piece, that Parkinson's is more than just tremor. And so I often tell patients that we want to aim higher. yes, of course, I want to treat your tremor, but I actually want to treat you as a whole person that is far beyond just tremor itself. We want to restore that kind of quality of life, restore that function, and that usually takes more than just treatment of tremor for Parkinson's.
Does the dopamine, is that enough to take care of all the other symptoms that come along besides tremor?
Right. So one of the diagnostic criteria of idiopathic Parkinson's disease is a response to dopamine therapy. So the good news is dopamine, as we replace that in your brain, it does improve the coordination and stiffness. One of the other probably misnomers, though, is that only 50% of Parkinson's patients' tremor gets better with dopamine. And so you could say, well, why do we use that if it doesn't affect tremor? And the reason we use that is in Parkinson's patients, we're trying to restore global function. So it's the one medicine that can get all three of those things better. But even if it doesn't get tremor better, we have other ways to treat tremor. And I want more than just tremor improvement. I want walking improvement, dexterity improvement, popping up out of the chair, being able to go exercise, being able to speak louder, move better, move more effortlessly. That's what we want. And that's exactly what dopamine therapy does. So it's a great therapy, but one of the keys to that is even if you are a Parkinson's patient and you don't feel like your medicine's working for you because you still have tremor, that doesn't mean the medicine's not working for you. It just means it's not treating your tremor. And we have so many other things that we can use to treat tremor in that setting.
Okay. So you pretty much covered the symptoms of Parkinson's disease. Is there a particular way this is diagnosed? And is it hereditary like essential tremor?
Yeah, so there is a particular way it's diagnosed. It too is diagnostic criteria. So what that means is it takes a clinician such as myself that has expertise in it to recognize the signs and symptoms of Parkinson's. And those are a lot of the things that we talked about. When we think about kind of, sorry, what was the other part of your question?
Well, what are we already talked about symptoms, but how is it diagnosed?
So just the diagnosis is really just kind of symptom recognition. So that slowness of movement, we call that bradykinesia. Again, those are the kind of decreased facial expression, the short steps, the kind of dexterity problems. In addition to tremor, tremor can be there. So tremor is there in about 70% of Parkinson's patients. And then muscle stiffness, we call that rigidity, is there in the vast majority of patients. And then last but not least, they can have a balance problem. It is also important when we think about the diagnosis of Parkinson's to recognize that we've spent a lot of time talking about the physical symptoms of Parkinson's. Parkinson's can also cause what we call non-physical symptoms as well. So these are things like sleep changes, sometimes thinking changes, sometimes mood changes, and sometimes actually GI and urinary changes. So it has a more complex kind of symptomatology.
It affects everything.
It can, and that's kind of related to that dopamine piece of it. And again, although it can affect a lot of things, the vast majority of those things are completely treatable. We just have to identify them first so we can treat them.
Okay, all right. Well, do you have any other really cool treatments over at R&I that you use for Parkinson's?
Yeah, so fortunately, the good news is deep brain stimulation therapy is absolutely wonderful therapy for Parkinson's. So just like we got done saying that focused ultrasound only treats the tremor in Parkinson's, deep brain stimulation therapy actually treats tremor, the slowness of movement, and the stiffness. So it gives you a much more holistic therapy. And so without a doubt, deep brain stimulation surgery is a superior therapy for Parkinson's patients because it's giving them much better control of the symptoms that are impacting their life. And absolutely, we use the latest technologies in all of the DBS therapies. And the biggest point of that is again, as overwhelming as it is to imagine having brain surgery, this really is standard of care. This is not experimental. This is not questionable whether it works. It works, it's highly effective, and it can absolutely improve symptoms and restore function in people's lives.
And you've been doing this for a long time at the
We
Rockefeller
have.
Neuroscience Institute. This
Absolutely.
is not really new.
Agreed, completely. The good news is, so I often tell patients, deep brain stimulation surgery has actually been around since the 1990s. The good news is, though, the technology has come a long way, much like the newest iPhone. We're not dealing with the iPhone 1.0, we're kind of in the newest technology. So although the therapy style and how we do it has been there for 30 years, our precision and expertise is even better today than it's ever been. So how do we use this therapy? How do we customize it? What are all the bells and whistles? What are all the newest advancements? We have those right here in the Rockefeller Neuroscience Institute.
Now, we've spent a lot of time talking about essential tremor and Parkinson's disease, but there are a lot of other movement disorders that you treat. Can you talk about, a few of the most common movement disorders that you deal with?
So I like to first describe what movement disorder neurology is. So
Okay.
I often think of it as if you can't move when you want to, that's movement disorders.
Okay.
Or if you're moving when you don't want to, that's movement disorders as well. So sometimes, in addition to, tremor is the most common movement disorder that we see. We spend a lot of time talking about that. But things even like tics or Tourette's fall into movement disorder, right?
Oh,
because in a
okay.
patient that is suffering from tics, they have a movement or a noise that they're making that they don't want to have, right? And then it's impacting their quality of life. And that's right in our kind of wheelhouse. It's exactly what we have expertise treating. Patients that are suffering from what we call dystonia, these kind of abnormal posturing. So sometimes they can have dystonia of their head or voice. They can have kind of a stiffness to their voice that can happen. And again, we can treat that. Patients can have unsteadiness in their walking. We call that ataxia, gait ataxia, or cerebellar conditions. That's right in our wheelhouse. And then although the population of Huntington's disease is quite low, meaning Huntington's disease is often kind of this disease that causes these dance-like kind of chaotic movements, highly genetic. Although the numbers of Huntington's patients are low, those are our areas of expertise to, again, understand what's impacting a patient's life, how we can get it better, and try to improve that quality of life.
Wow, that's a lot,
It is. And it's really fortunate because, when we think about access to movement neurology, it's really important probably for folks to know that if we even think about Parkinson's disease as a well-known movement disorder, only 9% of the United States country of patients affected with Parkinson's have ever seen a movement neurologist. 9%. That means
You're kidding.
I'm not kidding.
How are they getting diagnosed?
Right. So unfortunately, roughly 40% of them aren't being managed by any neurologist.
Oh my.
And so you really realize that the things that we have here at the Rockefeller Neuroscience Institute are not only cutting edge, but they're foundationally impactful, that we have access to experts that really are pretty access denied across the country. So it's really something
right in our front yard.
Right in our front yard, that's right. So we're really grateful for that, and the investment kind of from the Rockefeller Neuroscience Institute itself to really offer this kind of world-renowned care right here.
Are you working on any kind of research right now with movement disorders that's giving you hope and will give patients hope?
Yeah, so
What's the next cool thing?
Right. So many things. I think when we think about the biggest game changer in both of those conditions, essential tremor or Parkinson's disease, we'll talk about Parkinson's disease, would be a therapy that truly impacts the disease itself. So we talked a lot about that a lot of our treatments help the downstream signaling problem, but they don't fix the upstream problem itself, right? How we got there, right? And so one of the therapies that that had just completed some research phases is an infusion therapy that helps target the bad proteins that cause Parkinson's. And that it is an IV therapy that people can get. And the hope is that as we do that infusion, an IV therapy to target the bad proteins, it really decreases the number of those bad proteins, restoring function, or at least slowing down the disease progression. So it's super exciting. That just got published or kind of completed. That study just got completed, and we're hopeful to be one of the sites that's offering that in the kind of next 6 months to a year.
Is that monoclonal antibodies?
You're correct. It's a monoclonal antibody against alpha-synuclein. Alpha-synuclein is the bad protein in Parkinson's. Very similar to kind of the infusion therapies that we think about with Alzheimer's. Different as, again, Parkinson's is not Alzheimer's disease. They're very different, but the same kind of theory, the same kind of mechanism of action, just a different target.
Okay, good to know. So we're talking about all these cool things that are going on over at the Rockefeller Neuroscience Institute. Can you talk a little bit about the expertise of the team? I mean, what a gift.
It really is. So I couldn't agree more. It's been an absolutely wonderful journey to be part of the R&I. I started as faculty in 2016, and Dr. Rezai came here shortly thereafter in kind of late 2017. And really with his expertise and the culture of WVU medicine, we've been able to grow truly a world-renowned comprehensive movement disorder clinic. And that is absolutely because the team of experts we have, I would put up against anybody in the entire world. And I'm not just saying that because I'm biased, I'm here. I'm saying that because that is the type of team that we have. We are leaders in this field. We are truly treating patients from quite literally all over the country and a lot of patients internationally. What that means is people are physically flying to us from all over the world to have their care here in Morgantown, West Virginia. And that's a testament to our leadership. Of course, Dr. Rezai has been a huge impact in that. He's truly a world leader in functional neurosurgery, and his vision and culture and the kind of patient-centered, patient-first care has set the tone for the entire team. And we're all on board for, again, delivering the best product to every single patient we see.
You're all very passionate about it. I mean, every one of you. I mean, and again, I always say, you blow my mind on a regular basis.
We appreciate that, Mary. We appreciate the support.
Seriously.
And it's easy to be passionate about when you're kind of excited about the science and then you see the real life impact. And that's the reward piece of it. Again, I really feel like it is a wonderful privilege to be able to take care of patients with movement disorders because it's truly a joy to be paired with them, partnered with them, and together deliver the impacts that they want, right? Impact their quality of life so that they can live their life, and that can be the primary focus.
Yeah. So before we go, I want to ask you, what's the most important thing you want our viewers and listeners to know about movement disorders like essential tremor and Parkinson's?
So I want to first say that I think with any movement disorder like tremor, it's so cosmetic for so many people. Beyond the physical symptom, it's cosmetic. What I mean by that is that if I have tremor, often I'm not going to want to go out to eat with my friends. I don't want them to see it. There's so much stigma around having tremor, having Parkinson's, that it feels so isolating, I think, for patients and families that are impacted by it. They don't even want to talk about it. And that is the barrier we have to break down. Because if you can't talk about it and you don't seek therapy, we can't get you better. And the technology, the therapies, the treatment options we have are too good to accept that is any part of your life. We're too good at treating it to ever let that barrier keep you from getting better. So that is the number one most important thing I want to get out there is we are too good at treating this stuff for you to suffer in silence. Please see us, please ask for help. We're going to partner with you, and I assure you we're going to improve your quality of life.
You don't have to suffer. That's
Yes.
excellent. Thank you so much for sharing this information. It was really interesting. And
Thank you. Yes, thank you for having me. It's been a treat, and I can't, thank you all enough for getting the word out because I think my hope is, again,
let's get that number up
to where we're seeing expertise and making an impact, right?
Yeah.
Change the story.
Absolutely. All right, we're starting today. Here we go.
I love it. I love it.
So that brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information about movement disorders, visit wvumedicine.org/tremor. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast or the new Metro News TV app. I'm Mary Ravazio Menard, and on behalf of Dr. Murray and everyone at WVU Medicine, thanks for joining us.